webinar. We will wait a couple of minutes more in order to allow if someone arrives a bit late. Hi to everyone, and welcome to this BioS webinar, which is about commercial personalized genomic services in patient care. I'm Christis Vevis, and right next to me is Marianne Golau, both of us working at the German Oncology Center. Online is also present Marianne from BGU Murnau, who will help if needed during this webinar. The presentation is pre-recorded and will be available on BioS platform. Just to let you know, all participants are muted. After the presentation finishes, we will guide you through to answer a questionnaire and an evaluation form through Mentimeter. For any questions that might arise, please use the chat and you will get an answer as soon as possible, either through the chat or through mail. For now, I will mute myself as well, and I will start the presentation.
Dear colleagues, dear BioS participants, I welcome you in our webinar. My name is Konstantinos Ferentinos. I am a consultant radiation oncologist and the head of the Department of Radiation Oncology in German Oncology Center in Limassol, Cyprus. I will be your guide in the next 1.5 hours or so through our webinar. You have already learned many things about bioinformatics, biostatistics, various molecular analysis, assessment of big data, and many interesting aspects of computational biology. Our task today is to show you how we clinicians take advantage of all this information, how we combine this information, and how we use it in our everyday practice for the benefit of our patients. Oncology is a field in medicine which has evolved tremendously in the recent years. Owing to the close cooperation with molecular biology and bioinformatics, we have entered the era of personalized oncologic treatment, tailored according to each patient's tumor biology. Through the presentation of a clinical case, we would like to give you an idea how modern oncology works and how the different disciplines collaborate in order to provide the best possible therapy for each individual patient. To our clinical case now, we'll discuss about a 54-year-old lady, never smoker, with Asian origin and unremarkable past medical history, who presented to her GP due to persistent cough. The X-ray showed suspicious mass in the right hilum. A CT of the chest confirmed the suspicion of lung cancer with lung metastasis. MRI of the brain revealed asymptomatic brain metastasis. Biopsy of the primary confirmed the presence of a moderately differentiated adenocarcinoma of the lung. The classification was CT4, CN2, CM1, meaning a metastasized disease. Here you can see an axial slide of the chest CT of the patient. Here you can see the primary tumor, and with the green arrow you can see one of her lung metastases. And this is a sagittal view of the brain MRI, and you can see here these white spots. These are the brain metastases. What are the treatment options for this patient? Traditionally, therapy for metastatic non-small cell lung cancer, as well as for every metastatic cancer, was chemotherapy. However, a variety of genomic and epigenetic abnormalities, mutations, have been reported in non-small cell lung cancer. Oncogenic driver mutations are mutations that contribute to the initiation and maintenance of the cancer. They are, with other words, very important for the survival of the tumor cells. Non-small cell lung cancer can be subclassified by its genetic mutation profile, making personalized treatment for patients having these mutations feasible. These oncogenic driver mutations are a biomarker for the efficacy of newer so-called targeted therapeutics, meaning patients who have these mutations tend to respond better to these drugs. This is why the detection of these mutations is very important, and these mutations are detected with the next generation sequencing, or NGS. Dr. Alexia Iliadis from the NIPT Genetics Institute will explain us the method of next generation sequencing and its importance in modern oncology.
Hello everyone, my name is Alexia Iliadis. I'm a senior scientist at NIPT Genetics in Cyprus, and this is a company that specializes in research and development of genetic tests using next generation sequencing methodology for different fields in medical diagnostics, such as prenatal diagnosis, reproductive health, and oncology. So the focus today will be the application of next generation sequencing in oncology diagnostics. So in the following slides, I will go through the basic principles of next generation sequencing, or NGS for short, and I will show how it can be applied in the clinic for assessment of the molecular profile of the disease that can help guide the doctors to the most appropriate treatment. Next, I'll describe the NIPT Genetics developed test for tumor molecular profiling, and I will focus on the clinical utility of such tests in the diagnosis and treatment of non-small cell lung cancer. Next, I'll spend a couple of minutes on the importance of genetic testing for the diagnosis of hereditary cancer predisposing syndromes. And finally, I will talk about a non-invasive approach in oncology diagnostics, which is termed as liquid biopsy. So in this figure, you can see the improvements in the rate of DNA sequencing over the past 30 years or so and into the future. From gel-based systems to capillary sequencing and second-generation sequencing technologies, there has been more than 1 million-fold improvement in the rate of sequence generation over this time scale. DNA sequencing as we know it originated in the late 1970s when Frederick Sanger at the MRC Center in Cambridge developed a gel-based method that combined the DNA polymerase with a mixture of standard and chain-terminating nucleotides. When visualized with a gel electrophoresis, one reaction per lane, the fragments are sorted by length, and this allows DNA sequence to be read off base by base. So this technique was revolutionary at its time. It enabled the sequencing of 500 to 1,000 base pair fragments. By the 1980s, Sanger's original method had been automated by scientists at the Caltech, and large slab gels were replaced with acrylic finer capillaries. This technology, which was continuously improved over the years, served as the bedrock for the Human Genome Project. Now we're in the era of massively parallel sequencing, or next generation sequencing as we know it. The NGS platforms are now the dominant type of sequencing technology used today. Their extreme capacity allows for sequencing at a very low cost with a very high sensitivity. To date, these high throughput sequencing technologies have been applied in a variety of ways, such as whole genome sequencing, targeted sequencing, gene expression profiling, epigenetics, chromatin immunoprecipitation sequencing, and small RNA sequencing. And this really accelerated biological and biomedical research. In the context of this presentation, we will focus on targeted sequencing that allows deep sequencing of specific genomic areas of interest. In NIPT Genetics, we have leveraged the powerful technology we have developed for our prenatal diagnostic solutions, and we have tailored it to deliver superior performance, high accuracy, and reliability in the context of hereditary and somatic cancer testing. Briefly, the technology relies on a targeted design of probes called tags, and this is short for targeted capture sequences, which are coupled to magnetic beads. This in turn results in the activation of the capture constructs, which are then used to capture fragments of interest from the DNA library. This results in an enriched library of the targeted DNA fragments that are bound to the probes with high efficiency. The fragments are then eluted from the probes and subjected to NGS sequencing. Lastly, the sequencing data are then analyzed using bespoke bioinformatics pipelines. So what happens when the samples are loaded on the sequencer? So we are using a sequencing by synthesis NGS technology. And this technology uses the so-called bridge PCR for clonal amplification of individual DNA fragments. This PCR is performed on the flow cell, and this is a glass slide which is similar to a microscope slide, and on which the actual sequencing takes place. DNA fragments are linked via the adapters to the flow cell, and then bridge PCR is carried out. Oligos bound to the flow cell function as primers, and each individual DNA fragment forms a separate cluster of identical DNA fragments. And sequencing by synthesis is based on the cyclic reversible termination, or CRT method. Each of the 4 nucleotides is linked with a different dye and modified by a terminator group. During a reaction cycle, all 4 nucleotides are offered simultaneously to the polymerase for strand synthesis. After incorporation of a complementary nucleotide strand, elongation is no longer possible due to the blocking effect of the terminator group, and the 4 dyes of each nucleotide can be detected using imaging. The dye and the terminator group are cleaved, and a new synthesis cycle starts. The sequence of each cluster is thus simultaneously determined base by base. Using sophisticated bioinformatics, individual base sequences, reads, are aligned to and compared with a reference genome for mutation detection. Moving on now to the clinical utility of NGS in cancer diagnostics, we are now witnessing a fundamental change in cancer treatment in recent years. We're moving from a histopathologically defined tumor towards a genetically characterized disease, and this paves the way for targeted therapy. So there are now increasing requirements in molecular pathology for molecular testing, and it's now becoming a part of any patient with cancer. So now the challenge for clinical centers is to provide molecular testing so they can provide information for targeted therapy. And you can see in this graph the ever-increasing number of association of gene variants or gene mutations with drug associations. There are more than 700 variant gene-specific drug interactions with consensus or emerging therapeutic relevance. And as you can see here, lung adenocarcinoma is the cancer type with the highest number of gene variant drug associations. This need for advanced molecular tests in the ever-demanding field of tumor diagnostics is what we strive to fulfill. So we developed the Forsentian genetic tests that aim in identifying and analyzing clinically actionable variants across the wide spectrum of solid tumors. So Forsentian builds upon our existing technology to offer testing that will improve molecular classification of the tumor in form of available targeted therapies and the possibility to enroll in clinical trials. And it aims in improving the diagnosis and overall empower the clinician to offer a better informed clinical management. Just to briefly touch on the Forsentia somatic cancer test panels, the Forsentia offers extensive analysis of clinically actionable mutations that are implicated in many cancer types. It offers molecular classification of the tumor, and it's based on the NIPT genetics precision technology, which offers high sensitivity and specificity and reliable diagnostics. So we aim in identifying clinically actionable alterations that have a prognostic value or can guide treatment decisions which can elevate the chances for successful treatment through precision medicine and targeted therapies. And with Forsentia, we offer two categories of genetic tests. We have 6 comprehensive cancer-specific panels that aim in analyzing a specific set of genes that show high association with specific cancer, such as breast and ovarian, colorectal, prostate, glioma, melanoma, non-small cell cancer. We also offer a pan-cancer genetic test, which covers 76 genes with clinical actionability. And we also have a group of therapy-associated panels, which focus on a single or 2 gene testing, and these are genes that are directly associated with specific targeted therapies. So therapy-selected panels are carefully designed for their clinical actionability and their association with targeted testing and the necessity for testing in order to receive a selected targeted drug. So these panels focus on the identification of single nucleotide variants or indels, small insertions and deletions in hotspot regions of the genes tested. And this is cost competitive with a short turnaround time, and they're routinely requested by oncologists. And there are several approved targeted therapies and ongoing clinical trials focusing on these genes. So for example, EGFR testing is required before the patient receives any of the EGFR targeted therapies. KRAS and RAS positive patients show resistance to selected drugs, and PI3K positive patients in metastatic breast cancer are eligible to receive PI3K inhibitor treatment called alpelisib in conjunction with fulvestrant. BRAF positive patients can receive BRAF inhibitors, and INDH1, INDH2 is an important biomarker for the classification of glioma. And several clinical trials are now testing INDH1, INDH2 inhibitors in the context of glioma treatment. All the technical advantages of the NIPD genetics technology enable an unparalleled accuracy for single nucleotide variant, indel detection, translocation, as well as copy number alteration detection, with very high sensitivity and specificity that allows the identification of clinically actionable somatic alterations at even low variant allele frequencies. And all these features maximize the diagnostic power of these tests. Forsentia has a very simple process. The only thing needed is a sample from the tumor biopsy that has already been performed and sent to the histopathology lab. So there's no need for the patient to have another procedure. After the sample is received in the NIPD genetic lab, the results are sent to the healthcare provider within 2 to 3 weeks. Moving on to the clinical case we're presenting today. Non-small cell lung cancer is the most common type of lung cancer, and it's a tumor with a broad spectrum of targeted therapies that are either already available and approved by drug authorities, or they are investigated in clinical trials. The molecular characterization of non-small cell lung cancer tumors using next-generation sequencing technology has really become a key tool for facilitating treatment decisions and the clinical management of patients with non-small cell lung cancer. As you can see in this graph, these are data retrieved from the catalog of somatic mutations in cancer from the Sanger Institute in the UK, and they show the molecular mutational spectrum of the tumors analyzed, with EGFR being the most frequently mutated gene in non-small cell lung cancer, followed by KRAS, TP53, as well as other genes with lower frequencies in non-small cell lung cancer. NIPD Genetics offers the Forsentia non-small cell lung cancer gene test that includes 35 genes covering single nucleotide variant, indel detection, copy number alteration, as well as translocation detection for the selected genes. Then genes are carefully selected based on their association with approved therapy or with emerging therapeutic relevance, or they offer prognostic information. As you can see, the genes highlighted in red are the genes that are included in professional guidelines such as the National Comprehensive Cancer Network. In the table shown here is a list of genes recommended for testing by the National Comprehensive Cancer Network, along with their significance. And in the last column, you see the list of Forsentia tests that cover that specific gene or variant. For example, EGFR deletions on exon 19 or the exon 20 L858R substitution show responsiveness to tyrosine kinase therapy, and EGFR testing is included either in the non-small cell lung cancer panel or as a single EGFR testing panel or as part of the comprehensive pan-cancer panel covering 76 genes in total. Another example is ALK rearrangements, which show responsiveness to ALK tyrosine kinase inhibitors, which show improved efficacy for alectinib over crizotinib, and they're included either in the pan-cancer panel or the non-small cell lung cancer panel. Here you can see a summary table of targeted therapy or immunotherapy for advanced or metastatic disease in non-small cell lung cancer that is used either as first-line therapy or subsequent therapy. So genetic testing for the indicated genes is required for the administration of the associated targeted therapy. Back to the clinical case we're discussing in this module, we have a 54-year-old lady who is a never smoker with Asian origin and unremarkable past medical history. This lady went through transbronchial biopsy of the primary tumor that confirmed the presence of a moderately differentiated adenocarcinoma of the lung, and it was classified as stage 4B non-small cell lung cancer. So we perform molecular profiling testing using the non-small cell lung cancer panel. So molecular testing identified a deletion of 17 base pairs on exon 19 of the EGFR gene. You can see here the data from NGS testing where some sequencing reads have this deletion. And this is a frame shift deletion of 6 amino acids and an insertion of a serine amino acid in that position. EGFR exon 19 deletions are relatively common in lung adenocarcinoma patients. These type of deletions result in a constantly activated EGFR protein, even when it's not bound to its ligand, and this leads to tumor formation. EGFR exon 19 deletions, along with the exon 20 leucine to arginine substitution at position 858, account for 80 to 90% of all EGFR mutations found in non-small cell lung cancer, and exon 19 deletions show sensitivity to specific EGFR tyrosine kinase inhibitors such as osimertinib, and the molecular profile correlates strongly with the background and clinical characteristics of this patient. These exon 19 deletions are more frequently found in female patients over male patients, and they're more frequently found in never smokers of Asian descent with a diagnosis of lung adenocarcinoma. Now to switch gears a bit, another important aspect of oncology diagnostics is genetic testing for hereditary cancer predisposing syndromes. Obviously, the foremost benefit for hereditary cancer testing is the identification of individuals that are carriers for pathogenic variants that are associated with cancer predisposing syndromes. And this information can enable clinical action to be taken in order to reduce the risk of recurrence in patients or the risk of primary cancer in family members. For carriers with high-risk mutations that are very likely to develop cancer, prophylactic surgery is often the most preferred option. Overall, there are a lot of data that show that genetic testing and prophylactic surgery that is taken upon diagnosis can actually reduce the risk of cancer by even 90 to 95%. There's also a therapy potential in identifying mutations that can improve chemopreventing therapy and introduce targeted therapy in patients that are identified with a pathogenic variant. An excellent example of such case is the patients with a diagnosis of breast cancer that can receive PARP inhibitor treatment if they are positive for BRCA1 or BRCA2 mutation. Now, who should have hereditary cancer testing? Well, there are a lot of professional recommendation guidelines that suggest testing when there is a suspicion of a hereditary cancer syndrome. And there are some clinical features that are suggestive of such a syndrome. For example, when a cancer is diagnosed at an unusually young age, or if a person is diagnosed with several different types of cancer, or multiple primary tumors, such as bilateral breast cancer, or even when there is a lot of blood relatives from the same side of the family that are diagnosed with the same cancer type, or if there is an unusual representation of a specific cancer type, for example, breast cancer in men, and the presence of certain phenotypic characteristics that are associated with certain syndromes. Ancestry is also important. As you know, Ashkenazi Jewish ancestry has a higher probability of harboring hereditary mutations. And lastly, the occurrence of some cancer types have higher probability of harboring pathogenic variants, such as triple-negative breast cancer or epithelial ovarian breast cancer, or colorectal cancer with mismatch repair deficiency. There are certain clinical scenarios that multi-gene panel testing is recommended. For example, when the personal or family cancer history meets more than one hereditary cancer syndrome criteria, the doctor might choose to test more than one genes. In addition, when there's a personal history of multiple cancer diagnoses, it's usually hard to pinpoint a specific hereditary cancer syndrome. So the doctor might choose to test for multiple genes in order to increase the probability of identifying a pathogenic variant. In addition, when a first-line testing is inconclusive, the doctor might choose to test for a higher number of genes. For example, when you have a breast cancer patient with a suspicion of a hereditary cancer syndrome, and that patient underwent a first-line testing for just BRCA1 and BRCA2 genes. If that testing was negative, then the doctor might choose to offer testing for a higher number of genes to increase the probability of identifying a pathogenic variant in genes that go beyond the BRCA1 and BRCA2. And lastly, when there's a truncated family history, either due to adoption or family members dying in a young age for reasons unrelated to cancer, or even when the pedigree is lacking representation of the opposite test, the doctor might offer multi-gene panel testing. The clinical utility of multi-gene panel testing is documented in multiple studies, as you can see here, that show a higher percentage of patients with pathogenic variants is identified when a large number of genes are tested, as compared to just a single or two gene testing. So multi-gene testing in this setting is likely to alter the near-term cancer risk assessment and management recommendations for mutation-affected individuals across a broad spectrum of cancer-predisposing genes. So the procedure for Presentia hereditary cancer testing is very simple. We request a buccal swab to be sent to our laboratories, where the sample is processed and analyzed, and then a very comprehensive report is generated and then sent back to the clinician within 2 to 3 weeks. We have done an extensive review of the literature. We followed guidelines from several regulatory bodies, and we also consulted with oncologists and medical geneticists in order to develop genetic hereditary cancer panels with the maximum clinical utility. So you can see here the 19 gene panels for hereditary cancer testing. We covered a broad spectrum of cancer types, and we also include a pan-cancer gene panel covering 62 genes that are associated with cancer predisposing syndromes. And in all these panels, we can accurately detect different types of genetic alterations, including single nucleotide variants, small insertions and deletions, as well as copy number variations for all the genes included in these panels. In total, Presentia tests cover 24 hereditary cancer predisposing syndrome. And in this table, you can see all the syndromes covered in the different hereditary cancer panels. You can see here the Lee-Fraumeni syndrome with the TP53 gene, hereditary breast and ovarian cancer syndrome, testing for BRCA1 and BRCA2 gene, familial adenomatous polyposis covering the APC gene, and so on. So here you can see examples of the hereditary pathogenic mutations identified. Here is a single nucleotide variant identified in the BRCA1 gene. This is a T to G mutation that results in a cysteine to glycine substitution at position 61. And in this example, you can see the ability of our method and our bioinformatic algorithms that can reliably identify a deletion of 23 base pairs in the BRCA2 gene that results in an early termination of the protein sequence. Moving on to the patients that harbor small exonic deletions, these are patients that show deletions in the BRCA1 and MSH2 genes. The first is an example of a patient that we have identified a single exon deletion on BRCA1 gene, and this is exon 20 that was completely deleted. This is a second example of, again, a single exon deletion, this time on exon 23 of the BRCA1 gene. And the third one is a patient that had 7 exons deleted on the MSH2 gene, and this is associated with the Lynch syndrome. To finalize, I hope I was able to convince you of the value of genetic testing in oncology. Here in NIPD Genetics, we have a validated technology that covers multiple types of genomic alterations, and we provide quantitative and sensitive detection of variants with very high accuracy, sensitivity, and specificity. So the targeted NGS method that we use and the careful selection of the content of these genetic panels ensures a high clinical impact of these tests. For the Presentia hereditary cancer tests, information from this gene testing can enable early diagnosis, inform the clinician to make the appropriate clinical management, prophylactic surgery, and reduce the risk of developing cancer. In the case of Presentia somatic cancer testing, we offer a deep investigation into the tumor and offer information that can guide clinical therapy and inform on relevant clinical trials and offer prognostic information and overall a better clinical management. And to finish up, the next frontier in oncology diagnostics that is increasingly gaining ground is liquid biopsy. This is a non-invasive approach to molecularly characterize the tumor via the analysis of cell-free tumor DNA that is shed from the tumor into the bloodstream. So at NIPD Genetics, we are now developing a liquid biopsy test that can identify tumor-related mutations in the patient's plasma. Liquid biopsy testing can be used for the diagnosis of cancer or in order to detect residual disease after surgery, to monitor response to therapy, as well as follow-up monitoring throughout treatment, and to detect genetic alterations that are associated with drug resistance. This application can actually have immense clinical utility in various solid tumor malignancies, including non-small cell lung cancer. For example, liquid biopsy can be used for monitoring response on tyrosine kinase therapy. If during tyrosine kinase treatment, a resistant EGFR T790M mutation is identified, then the doctor can decide to change the treatment and give the patient osimertinib, which is a third-generation tyrosine kinase inhibitor that is approved for patients with this type of genetic mutation.
Thank you very much, Alexia, for this excellent talk. Alexia gave us an insight into the various genetic tests that we can run and can help us and guide us to choose the right treatment according to the biology of the tumor. Back to our clinical case now. The NGS revealed a mutation in the EGFR gene, an exon 19 deletion. The patient was started on osimertinib, a third-generation EGFR tyrosine kinase inhibitor. Elena Fouzila, medical oncologist and genetic counselor from Thessaloniki, Greece, will present us the options we have in modern oncology for patients harboring driver mutations.
Tumor molecular profiling has been extensively used for the exploration of mechanisms of tumorigenesis and mechanisms of resistance to anti-cancer therapies. Importantly, it plays a critical role in the identification of prognostic and predictive biomarkers. In 1990, lung cancer was considered to be one disease, and all patients were treated using the same therapeutic approach. A few years later, we noted that there were subgroups within lung cancer based on the tumor histological characteristics. The two major subgroups were non-small cell lung cancer, which represents 85% of the cases, and small cell lung cancer. Then, investigators realized that non-small cell lung cancer is a heterogeneous disease that is typically classified into two broad subgroups, adenocarcinoma and squamous cell carcinoma, along with other rare tumor histological subtypes using standard pathology methods. These subtypes differ on the morphologic characteristics, immunohistochemical phenotype, and tumor molecular profiling. In addition to the histological classification, we now use the molecular classification, where based on tumor molecular profiling, each tumor's unique characteristics are identified and then used for treatment selection. The investigation of innovative treatments originates from the need to improve clinical outcomes of patients with non-small cell lung cancer. The median overall survival of patients who do not receive any treatment for advanced non-small cell lung cancer is 3 to 4 months, while with the addition of chemotherapy, the median overall survival reaches 12 months. Various efforts have shown similar clinical outcomes with any platinum-based chemotherapy combination. Therefore, the identification of innovative treatments that will improve patient outcomes is warranted. Indeed, the use of targeted treatments has changed the therapeutic landscape of lung cancer and has significantly improved patient clinical outcomes, with the median overall survival to be longer than 24 months. Therefore, nowadays, in addition to stage, age, performance status, and comorbidities of the patient, we also examine the histological subtype and, most importantly, tumor biology, which plays a critical role in treatment selection. The evolving strategy of treatment selection using the precision medicine approach uses the patient's tumor or cell-free DNA analysis, the immune markers, and other biological features, along with patient characteristics and comorbidities, to determine the optimal treatment to individual patients. Through tissue or liquid biopsy, we examine the specific molecular alterations and select patients' treatment based on this information. The result that we expect is a significant improvement in tumor burden and ideally complete tumor response. For the past decade, we have been investigating the presence of specific targetable molecular alterations, including EGFR, ALK, and ROS1, based on the available respective targeted treatments. We use Sanger sequencing and fluorescent in situ hybridization. Tumor next-generation sequencing has accelerated the development of innovative therapies. The improvement of next-generation sequencing technologies enables the completion of tumor and cell-free molecular profiling more efficiently and in a shorter time frame compared to older technologies. Comprehensive panels with large number of genes that also include immune signatures and RNA profiling are currently being developed and used in clinical trials. So the number of targets has been significantly increased compared to previous years. What we also need to keep in mind is that metastatic tumors are molecularly heterogeneous, and consequently, drugs targeting the molecular alterations of one lesion might not be effective in all metastatic tumor lesions. Additionally, tumors constantly evolve, especially under the pressure of anti-cancer therapies. Therefore, a more efficient method for longitudinal tumor molecular profiling is warranted. During the past years, investigators are developing methods for genomic analysis of plasma cell-free DNA for the detection and characterization of molecular alterations. ctDNA genotyping is cost-effective, and more importantly, it is a non-invasive tool to identify and monitor the evolution of molecular abnormalities and thus optimize the treatment. Now that a large number of alterations are being identified in each tumor, it is important to identify the driver ones, the ones that are critical for tumor cell proliferation and survival. Lung Cancer Mutation Consortium demonstrated that patients who received targeted treatments for driver alterations had longer overall survival compared to patients who did not receive targeted treatments or who did not have targetable driver alterations. Targeted treatments in patients with non-small cell lung cancer have been shown to lead to high response rates and fast responses. They are associated with decreased adverse events compared to chemotherapy, and they are also cost-effective. The high efficacy of these targeted treatments is important not only for the increase in progression-free survival, but also for the rapid and significant improvement of symptoms and quality of life. As you see in the scans, targeted treatments are not only active in the primary tumor, but also in the metastatic lesions, even in the brain. This is particularly important for patients with high tumor burden, where there is a need for rapid improvement of symptoms. Patients with non-small cell lung cancer may suffer from symptoms of dyspnea, chest pain, cough, which decrease significantly the quality of life. In a significant proportion of patients with non-small cell lung cancer, brain metastatic lesions are diagnosed in the beginning or throughout the disease. Novel targeted treatments are also effective and active in the brain, leading to partial or complete responses. The most common targetable molecular alterations in patients with non-small cell lung cancer are EGFR mutations. EGFR mutations are identified in 10 to 15% of European patients with non-small cell lung cancer. They are most commonly identified in women, in younger patients, patients who are non-smokers or light smokers, and patients with adenocarcinoma. The EGFR is a receptor tyrosine kinase that controls cell growth and proliferation via transduction signaling pathway. It has an extracellular ligand binding domain and transmembrane domain, and intracellular tyrosine kinase and regulatory domains. When a specific ligand for example, epidermal growth factor, binds to the EGFR, the normally functioning EGFR undergoes conformational change, and the intracellular domain is now phosphorylated, leading to downstream signal transduction by various pathways. The EGFR mutation may lead to overexpression of the tyrosine kinase domain in the cell membrane. The result of this is upregulated cell growth and eventually uncontrolled cell proliferation. In non-small cell lung cancer, the majority of mutations are found within exons 18 to 21. Deletions in exon 19 and the point mutation of L858R in exon 21 constitute about 90% of all activating mutations. These are termed classical activating mutations. These alterations can result in constitutive activation of signal transduction pathways, leading to cell proliferation or evasion of apoptosis, regardless of the presence of an extracellular ligand. Less common mutations occur in exon 18 and 20, which appear not to be activating. Exon 18 point mutations are thought to represent 3 to 4 of all EGFR mutations. Not all mutations in these exons are activating. Studies have shown that EGFR inhibitors in patients with selected mutations in those exons 18 and 20 lead to very low percentages of response and very short progression-free survival. Gefitinib was the first selective inhibitor of EGFR tyrosine kinase domain. Activating mutations in EGFR have been shown to confer increased sensitivity to tyrosine kinase inhibitors, including gefitinib, erlotinib, afatinib, and osimertinib. Gefitinib binds to the ATP binding site of the enzyme. Thus, it inhibits the function of the EGFR tyrosine kinase, inactivating the signal transduction cascade and cell proliferation. Clinical trials show that the administration of EGFR inhibitors to patients with EGFR activating mutations was associated with improved clinical outcomes compared to standard chemotherapy. Patients who received EGFR inhibitors had a significantly longer median progression-free survival, 11 months versus 5 months compared to patients who received chemotherapy, as well as higher response rates, 74 versus 31% respectively. However, tumor cells find ways to overcome the sensitivity to EGFR inhibitors and to become resistant to treatment. One of the most important mechanisms of resistance, acquired resistance, is the emergence of T790M mutation. The substitution of threonine to methionine at the gatekeeper amino acid 790 leads to a bulkier site that prohibits EGFR inhibitors from binding to that site, and then they lose potency. The affinity of ATP at EGFR kinase domain recovers, which enables the kinase phosphorylation and thereby activation of the signaling pathways associated with cell proliferation and tumor progression. This knowledge was very useful because it led to the identification of a novel drug, third-generation EGFR inhibitor. This drug irreversibly and selectively inhibits both activating and EGFR 790M resistance mutations, and at the same time shows lower activity against wild-type EGFR, and is associated with lower rates of adverse events. It also crosses the blood-brain barrier and penetrates the central nervous system. A phase 3 trial compared first-line osimertinib with older EGFR TKIs in patients with EGFR-positive advanced non-small cell lung cancer. The trial showed that patients who received osimertinib had longer progression-free survival compared to patients who received other TKIs, 19 to 10 months respectively. The objective response rate was similar in the two groups. A consistent benefit of osimertinib over older EGFR TKIs in terms of progression-free survival was shown across all predefined subgroups, including patients with and without metastasis in the central nervous system. Data from the overall survival analysis was recently reported. The median overall survival of patients who received osimertinib was 38 months compared to 32 months in patients who received standard EGFR inhibitors. At 3 years, 28% of patients in the osimertinib group versus 9% in the comparator group were continuing to receive the trial regimen. There is no doubt that EGFR inhibitors, among other targeted treatments, have changed the therapeutic landscape of non-small cell lung cancer, providing significant clinical benefit to selected patients while exhibiting favorable toxicity profiles. The ultimate goal is to identify the specific molecular alterations of each patient's tumor and target the driver ones with a potent treatment agent. EGFR inhibitors are a successful example of implementing precision medicine to patients with cancer. We continue to improve this implementation of precision medicine by identification of mechanisms of carcinogenesis for every patient, discovery of innovative drugs, and use of personalized therapy that effectively inhibits the function of the driver biological alterations to patients with cancer. Targeted therapy, immunotherapy, T-cell therapy alone or in combination with cytotoxic or other effective therapeutic strategies need to be offered to all patients and have the potential to cure cancer.
Thank you very much, Elena, for your excellent talk. You see that modern oncology has evolved and the therapeutic armamentarium is getting richer with drugs that aim at personalized treatment. To our patient now, she had a very good response to the treatment with TKIs. The brain metastases have responded to. After approximately 2 years, a CT scan suggested progression of one of the lung metastases. The progressive disease was verified by an FDG PET-CT scan, which confirmed the presence of an oligoprogressive disease. You can see here the progressive metastasis in coronal and axial view. Dr. Alexis Vrahimis, nuclear medicine doctor and head of the Department for Nuclear Medicine in our center, will explain you what this hybrid examination, this PET-CT is, and what is the role of nuclear medicine in modern oncology.
Nowadays, we have a variety of different imaging techniques. So our duty is to choose the right imaging modality based on the medical question and what we want to visualize. So we can go through morphology to function and molecules, choosing a different modality. So in the PET-CT, we can combine the morphology delivered from the CT component with function and molecules delivered from the PET component. As we have said, there are different ways to image the same anatomical area. So based on the indication, we have to choose the right modality. As you can see, the same anatomical area, such as the hand, can be visualized with different ways, such as an X-ray, a scintigraphy, an MRI, or optical imaging, delivering different information that are important for the diagnosis. All nuclear medicine techniques are based on the radiotracer principle that was first described in 1923 from George de Hevesy, that described the distribution of radioactive lead in fava beans. This also led him to win the Nobel Prize for Chemistry in 1943. So let's see how this radiotracer principle works. Small amounts of a radioactive substance are administered to the patient. This substance is called radiotracer or radiopharmacon. Now, this substance has a specific target within the human body. This target, this biological target, has a very high affinity with the radiopharmacon. Now, the radiopharmacon is composed from two main components, the carrier and the isotope. The carrier is what we are using in order to identify this biological target within the human body. The isotope is used in order to give us externally information on the localization of this biological target. The signal arising from this biological target is detected using special machinery such as the SPECT or the PET systems. The difference with the classical radiological procedures is that in the later the transmission is used. When we are using transmission, that means that we are transmitting an X-ray that is traveling through the human body, and on the other side of the human body, we are measuring the influence of the attenuation that has occurred through this traveling of the X-ray. And by this, we can indirectly visualize the density of the structures from which this X-ray has traveled. Differently, in the emission that is used with the nuclear medicine techniques, we are injecting the radioactive source. So the source is right now within the human body and delivers a signal that is detected outside of the patient. So this is the basic difference on the technique used between the classic radiological procedures and the nuclear medicine procedures.
Radiation exposure is a daily phenomenon and can be found everywhere. The way our body sums up radiation exposure is irrelevant. This can be measured using a value called sievert. As you can see, also activities of normal life, such as transatlantic flight, equals to a significant amount of radiation exposure. Furthermore, you can also see that the mythos that radiation exposure is higher when it comes to nuclear medicine techniques because they deal with radioactive material. As you can see, even the FDG PET-CT examination is often related to lower radiation exposure as compared with radiological procedures such as a computed tomography of the abdomen.
To better understand PET, we have to see a bit into nuclear physics. If you can recall, the radiopharmacon has a part called isotope. This isotope, in the case of PET, is composed of unstable nuclei that have a higher amount of protons. When returning to normality, these protons decay in neutrons and positive electrons called positrons and neutrinos. Let's concentrate on the positron. When traveling into matter, this positron comes and meets with an electron that is antimatter for it. When these two meet, they annihilate, and in their position we have a special gamma energy of 511 kiloelectron volts with an angle of about 180 degrees. Most PET isotopes are produced using cyclotrons. Cyclotrons are cyclic accelerators that accelerate protons and lead them to hit or bombard a non-radioactive substance in order to produce a radioactive material such as fluor-18. As you may recall from the first slides, the radiation source in nuclear medicine techniques is located within the patient. So in the example of PET, the radioactive source finds its way in our organ of interest and emits a special gamma ray, as previously explained. These gamma ray are two photons of specific energy that have an angle of approximately 180 degrees. This is what makes PET so unique. It can detect these special annihilation photons. So after having registered a lot of these photons, the software can process and give us a reconstructed image of the radioactivity distribution within the examined body. You can find more information in the link that is provided in this nice YouTube film produced from colleagues in the UK. In the case of hybrid machinery, such as a PET-CT, we can combine the information provided from both modalities. So in the case of CT, we can have information regarding location, size, structure, density, etc. So in the example provided, we have a patient having metastasis with a primary cancer of Ewing sarcoma. On the other hand, the PET component can provide us information about molecules. By this, we can assess cellular function, molecular pathways, we can do quantification, cell tracking, etc. So the same patient has a completely different image as compared to the normal CT examination. Combining the information provided from each modality in separate, we can have a hybrid image of a PET-CT. In this, we can use the strengths of each modality to deliver a better and more holistic approach for the diagnosis of the patient. So in this specific case, we can see different bone lesions not visualized in the CT examination, but having a pathological signal in the PET examination. And we can tell exactly using the CT component from which bone areas this pathological signal is coming from, so that the treating physician will provide a better and more tailor-made treatment. Just like scintigraphy, when we are talking about PET, we are not dealing with always the same examination. As you can see in this slide, there are 5 different examples of a PET examination. As you see, the distribution and the images acquired are different from one another. The reason for that is that we are using a different radiopharmacon for each case. So it is of major importance to understand the medical question and choose the proper radiopharmacon in order to answer the question as better as we can. For the radiopharmacon procedure and production, we are in need of an isotope, as we have previously discussed, in our case fluor 18, that is marked with different precursors or substances in order to produce the radiopharmacon in need. These images show examples of the hardware needed for such production. After being produced, the radiopharmacon has to undergo several quality controls in order for us to be assured that it represents and meets all the needs of the radiopharmacopoeia. This procedure is ideally being performed from trained radiochemists. By far, the most common PET radiopharmacon used currently in oncology is FDG. FDG is an abbreviation for fluorodeoxyglucose. Simplified, we are talking about radioactive sugar. Radioactive sugar is taken up from the cells just like glucose. It undergoes a metabolism through the enzyme hexokinase, and it's turned to FDG6 phosphate. Normally, sugar goes further on a metabolism with another enzyme called phosphoglucose isomerase. However, due to the modification of our radiopharmacon, this cannot happen, and it leads to an intracellular trapping of FDG6 phosphate that is, of course, radioactive. Through this radioactivity trapping and using PET technology, we can assess indirectly the glucose metabolism of the whole body. If we want to be precise, what we are looking at when looking at a PET image of an FDG, we are looking at glucose transport and hexokinase activity. Both these procedures are supposed to be increased when we're talking about malignant tumors. So what we are using in order to get our PET images and come to a diagnosis is the increased glucose utilization that is elevated in malignant lesions. In the case previously discussed of the lady with the non-small cell cancer, we were called to perform an FDG PET in order to assess treatment response and especially further clarify some questionable lesions seen on CT. In the images, we see FDG uptake in organs such as brain and heart muscle that have normally high needs in energy and sugar, but also the urinary bladder through the renal elimination of the tracer. However, the uptake in the lungs, as displayed with the red arrow, is abnormal. The lesion can be visualized three-dimensional and in each modality in separate. In the left-hand side, we can see the CT with an equivocal lesion of the right lung. This lesion has also a very high FDG uptake, as seen in the PET images in the middle, corresponding to a pulmonary metastasis. On the right-hand side, you can see the overlay of these two modalities. These pulmonary metastases can also be visualized in different views, such as the coronary view, and different windows, such as the lung window, shown in the CT examination. Furthermore, a second lesion seen in the CT examination, as shown with the lower arrow, is non-FDG avid, and despite its equivocal characteristics in the CT examination, can be withdrawn that this lesion is non-avid and non-viable, and it corresponds to a complete response after treatment. So as compared with the CT examination, the benefit of the FDG is that it will go beyond morphology and depict active and vital tumor cells that are essential in order to plan the appropriate treatment for this patient. Similarly, a CT visualized mass adjacent to the left breast that probably represents lymph nodes is non-FDG avid, as detected in the fusion PET CT, and it also corresponds to non-viable remnants after treatment. As you have seen from the case presentation, brain has normally a high glucose utilization. Therefore, in many cases, metastasis in the brain cannot be adequately assessed due to the normally elevated FDG uptake of the brain parenchyma that does not allow a good metabolic contrasting when it comes to brain lesions. In such cases, if we want to image some suspicious brain lesions, for example, in case of primary brain tumors, we can therefore use other radiopharmaceuticals, such as the fluoretyl tyrosine, that do not have a normally high uptake in the brain and can be better assessed. In such cases, the MRI is also the gold standard that will show us the lesions needed. Another limitation of the FDG is its lack of specificity, as the glucose is being taken up also from other cells, such as, example, inflammation cells. So in case of inflammation, elevated FDG uptake can also be noted that could in some cases be misinterpreted as tumor or will lead to further investigation. Nevertheless, depending on the pattern of the uptake, the medical history, the anatomical information, and the experience of the reader, these pitfalls can be reduced. In our case, we see an inhomogeneous uptake in both breasts. that is in our case compatible to foreign body reaction to the breast implants and cannot be easily misinterpreted with vital tumor.
Thank you very much, Alexis, for this very nice talk. As we have seen, PET-CT is a very useful examination in oncology. It can reveal us tumors in very early stages where conventional imaging might fail. Back to our clinical case now. After confirmation of the oligoprogressive disease, the patient was referred to us for stereotactic radiotherapy of the metastasis. Yannis Oursakis and Paul Doolan, both coordinators of the Department of Medical Physics in our center, will explain you what radiotherapy is, will describe briefly the basics in physics of radiotherapy, and present you the technology behind radiotherapy.
Hello everyone. This presentation will provide a quick overview of some medical physics aspects in radiotherapy. My name is Dr. Yannis Oursakis. I am the Deputy Coordinator of Medical Physics in Radiotherapy and Coordinator of Medical Physics Education and Research Program at the German Oncology Center. I will present the first two topics and will be followed by Dr. Paul Doolan. So in this presentation, we will outline the basic principles of radiotherapy, and we will have a look at the most common types of equipment used for external beam radiotherapy, namely the nonlinear accelerator. We will then have a glimpse of the evolution of different techniques, and finally have a look at some of the prerequisites for the state-of-the-art technique called stereotactic radiotherapy. So let's start with the basic principles of radiotherapy. And first of all, let's see what radiotherapy is, what it means. Radiotherapy is the treatment of disease, typically but not always cancer, with ionizing radiation. Like surgery, radiotherapy is a local treatment. We mentioned ionizing radiation, but what is radiation anyway? Radiation is generally energy that travels in the form of waves, also called electromagnetic radiation, or particles. The figure here shows the electromagnetic spectrum. Starting on the left, we have low energy, long wavelength, low frequency waves, such as the ones seen around power grid lines, radio waves, microwaves, and so on. In the middle of the figure, you can see the visible spectrum, which is the light colors that we can see with our eyes. Up till these energies, we have the so-called non-ionizing radiations. High energy ultraviolet radiation, X-rays and gamma rays have higher energies, shorter wavelength, and higher frequency. These are the ones we call ionizing radiation. What is ionizing radiation then? Ionizing radiation is the radiation that has high enough energy to potentially remove electrons from atoms with which it interacts. A simplified animation of an ionizing radiation example called the Compton effect is seen here. An incoming photon interacts with an electron of a specific atom, giving it enough energy and removing it from the atom. Non-ionizing radiation, on the other hand, is the radiation that does not have enough energy to potentially remove electrons from atoms with which it interacts. Clinical radiotherapy typically utilizes X-rays, gamma rays, electrons, protons, or other ions. X-rays, though, are employed for the majority of the treatments. Now, let's have a look at the medical linear accelerator. A medical linear accelerator is the most common type of equipment used for the delivery of external beam radiotherapy. Examples of clinical machines from the two companies with the largest market share are shown here. This is a schematic representation of the components under the hood of a common clinical medical linear accelerator. Essentially, a medical LINAC, in most cases, generates a highly energetic beam of X-rays that are shaped and directed towards the patient. This X-ray generation is achieved following the acceleration of electrons in a linear accelerator, hence the name of the machine, and the subsequent interaction of these electrons with a metal target. Now let's see some of the main components of the LINAC. Electrons are accelerated to very high speed, hence high energies, and reach the so-called LINAC treatment head, which itself has many components. The production of X-rays happens at the X-ray target. The X-ray target is a small piece of metal typically made out of tungsten. The accelerated, highly energetic incident electrons interact with the tungsten with several types of interaction. The most important one, here represented by the letter B, is called the Bremsstrahlung radiation, or breaking radiation. During this, electrons interact with the atom's nucleus. They lose energy while changing direction, and this energy is released in the form of an X-ray photon. A continuous spectrum of X-ray energies are generated through this type of interaction. The other main interactions result in heat generation and production of so-called characteristic X-rays. Produced at the X-ray target is directed towards the patient and has a pyramid-like shape. At about 1 meter distance from the point of production, where the patient is typically placed, this beam reaches a size of about 30 by 30 centimeters. The beam is therefore collimated or shaped to the size and form needed for a precise treatment using two types of dynamic collimators. The first one is called the secondary collimator. The names diaphragms or jaws are also used. These two diaphragms can open and close to limit the size of the beam as needed. The next stage of beam shaping is achieved by the multi-leaf collimator, or simply MLC. This has a large number, typically around 160, of tall and thin collimators and can independently and dynamically move. As seen in the animation, various complex beam shapes can be dynamically generated.
Hello everybody, my name is Dr. Paul Doolin. I am the General Coordinator of Medical Physics here at the German Oncology Centre, and I will be continuing the presentation from this point forward. I'm going to discuss the final two topics of our talk today. I will start with the evolution of radiotherapy from an era of 2D to the current state-of-the-art stereotactic radiotherapy. Then I will discuss the prerequisites for a centre to start a stereotactic radiotherapy program. If we look at a timeline of radiotherapy through the years, it can be demonstrated as shown here from left to right. We began with an era of 2D planning in the 70s, moved to 3D conformal radiotherapy in the 80s and 90s, then moved to intensity modulated radiotherapy, or IMRT, in the 2000s. This was delivered as a volumetric modulated arc therapy, or VMAT, from around 2008. And for the past 5 to 10 years, the community has been practicing regularly stereotactic body radiation therapy, or SBRT, and stereotactic radiosurgery. So let's look at a case of 2D planning. As the name suggests, this involves creating fields based on 2D images of the patient, typically in the anterior, superior, and lateral directions. The fields were simple in shape, owing to the technology available at the time, but it was known that improvements in shielding dose to critical organs could be made. After the successful implementation of radiation treatment planning systems in the late 80s, it was possible to design radiation fields in 3 dimensions. Additionally, as the hardware improved with the implementation of multi-leaf collimators, these are small collimator leaves that shape the beam to match the shape of the tumour from a specific direction, more complex shapes could be designed. With a summation of multiple uniform beams from different directions, a radiation dose conformal to the patient's tumour could be designed, hence the name 3D conformal radiotherapy. A further development suggested the idea that instead of using uniform dose beams from different directions, non-uniform dose beams could be used. Now, the advantage of using non-uniform beams is that you can spare dose on the entry from some directions more than others, and thus generate an even more conformal dose to the target. The disadvantage, though, is that typically IMRT requires the use of more radiation beams, and thus low doses are spread out to more different areas than for 3D conformal radiotherapy. Volumetric modulated arc therapy, or VMAT, is an extension of IMRT to deliver the radiation dose using beams following an arc trajectory rather than static positions around the patient. The advantage of this is that you have many more angles to work with and the potential to generate many more different shapes and beam doses, which leads to excellent conformality of radiation dose to the target. The disadvantage, however, is the spread of low dose throughout the patient, known as the low dose bath, for which it is not yet known the effect on the patient. But logically, it's thought that limiting the spread of the high radiation through this technique has a bigger benefit than the potential increase of secondary cancer risk caused by the low dose bath. Stereotactic radiotherapy is an extension of VMAT for specialized cases that are typically very small in size and or have very high dose per fraction, require more accurate precision than VMAT. Typically, we're talking about setting up the patient and the tumor with precision of 1 millimeter. Okay, so this video shows what a radiation field looks like on a modern-day radiotherapy Linux skeleton. What we can see here is the radiation beam in yellow, shining down from the top, and being shaped by the many small multi-leaf collimators. The shaping is effectively showing a shadow on the treatment bed, which would match the shape of the tumor. In VMAT treatments, the radiation beam would rotate around the patient at the same time as this shape changing to create a very conformal radiotherapy dose. Okay, so let's look at a specific 3D CRT patient case. In our radiotherapy treatment planning system, we can determine the beams that we need to deliver to get a conformal radiation dose to the tumor. Now, before the patient comes for their treatment, they would have a CT scan, and based on this, we can make the patient-specific treatment plan. In this case, we have designed a beam to come from one side of the patient. I should add that in the next few diagrams, radiation dose is shown as a color overlay on top of the patient's CT scan, where red is more dose and blue is less dose. Additionally, the shape of the radiation beam created by the multi-leaf collimators is shown in the small diagrams in the red boxes. If we add another beam from the other side of the patient, we get a spread of dose to the lateral edges of the patient. If we want to reduce the dose laterally, we can do so by adding a posterior beam. We can then optimize the weighting of these beams to reduce the dose on the areas outside of the tumor. And finally, we could add wedges to the lateral beams to provide a uniform distribution of dose in the center of the tumor. And this would be fairly close to a final result for a clinical 3D conformal radiotherapy plan. Okay, now I would like to show you the principles of a VMAT plan. Remember, this involves the delivery of radiation along an arc around the patient. Let's say we have a tumor like that shown here in pink. With 3D CRT, we would start typically with 3 or 4 beams from different directions around the patient. But we could just as easily increase this number to 8 beams or to 16 beams, or actually from a continuous series of directions around the patient. And this is actually the principle of VMAT planning. To get the most conformal dose, we could then change the weighting of each of these beams and then create different shapes from each direction. To add further complication, we could even say that the shape from each direction doesn't necessarily need to match the shape of the tumor from that direction. It could be a non-uniform shape, but the important thing is that the dose at the end follows the shape of the tumor. So the following result would look something like this. And this is a great example of the power of VMAT treatments, whereby we're delivering high dose to the tumor and are still able to spare radiation dose to the critical organs, in this case, the bladder. Now, if we consider the number of angles that we have to think about, the weight of each of these beams, the shape of each of these beams, there are just too many variables, even for us physicists to think about. So this work is handled by a mathematical optimizer, which finds the best solution for us. If we need to change the plan, the request that we give to the optimizer must be altered, and the new solution will be found by the optimizer. The time to arrive at the optimal solution, not only the computational time, but also the time to decide on the correct requests for the optimizer, takes anywhere between 1 hour and 2 days, depending on the complexity of the target shape. Okay, so now that I have sold you on how VMAT is the most advanced delivery and stereotactic radiotherapy is essentially an extension of that, what do you actually need to set up a stereotactic radiotherapy program in your center? Okay, so let's start by looking at what are the differences between VMAT and stereotactic radiotherapy. Well, stereotactic radiotherapy requires excellent immobilization of the patient, a very high level of image guidance, very high precision in the delivery of the radiation dose, and typically relatively small field sizes. It's characterized essentially by higher dose per fraction and fewer fractions in total. Here are some of the immobilization device comparisons between VMAT and SBRT. You can see that the body vacuum bags also have an abdominal compression with SBRT. This is optional. And in some centers, a mouth bite and nose compression is used for the stereotactic brain cases. The aim of both of these is to ensure that we set up the patient in exactly the same position for every treatment, every day. In terms of image guidance, SBRT would typically require us to use some radio-opaque markers inside the patient, either close to or inside the tumor, with which we can set up the patient more accurately. These are known as fiduciary markers. Additionally, we can take an image of the patient when they're set up ready for treatment, just to show us how their internal organs are moving. So this is a 4D, this is a three-dimensional, but also in time dimension, home beam CT. So this video aims to explain this more clearly. We have the linear accelerator rotating around the patient, acquiring a cone beam X-ray CT image of the patient and its tumor location. As it does so, the breathing cycle of the patient is detected, and the images acquired are sorted into the different phases of the breathing cycle. At the end, we essentially have a video of the movement of the patient's internal organs, which is correlated with this breathing cycle. For high precision delivery, we have a few different techniques, one of which is to control the breathing and only deliver radiation when the tumor is in a specific position, which is related to the breathing cycle. And another is to adjust the patient position before treating using a specialized treatment bed that can rotate in 6 different directions. This is called the hexapod. So as we see here in the video, the hexapod couch that we use can rotate in all 6 degrees of freedom. So that brings our presentation to a close. We have discussed the principles of radiotherapy, the LINAC, discussed the evolution from 2D radiotherapy to stereotactic radiotherapy, and briefly discussed some of the additional equipment needed to start a stereotactic radiotherapy program. Both Yanis and I would like to thank you for your attention, and we invite any questions you have. Thank you very much.
So, thank you very much, Paul and Yanis, for the very nice presentation. The colleagues showed us what is radiotherapy and what are the physical principles of radiotherapy. But now, let's move on to the biology of radiotherapy. As we have already learned, the particles that are responsible for the biological effect in radiotherapy are photons. There are some other particles too, such as protons or other heavy ions, but the vast majority of radiotherapy is being conducted with photons, so we will focus on them. First of all, the target molecule in the cell for generating biological effect is the DNA here. When the photons enter the body, they deposit energy as they travel through it. This energy deposition causes ionization by ejecting orbital electrons from the atoms. This phenomenon, the ionization, was demonstrated previously. Now, these free electrons can either directly hit the DNA, or more commonly, and because water molecules are by far the most abundant molecule in the cell, they hit the water molecules here and create hydroxyl radicals. These free radicals in turn interact with the DNA, causing damage. Cell killing by this indirect action through water constitutes some 70% of the total damage produced in the DNA. Radiation causes various damages to the DNA, such as base loss, base modifications, single-strand breaks, and the most serious double-strand breaks. Radiotherapy with only one gray is the measurement unit for the radiotherapy dose, can cause approximately 4,000 to 5,000 DNA damages in each cell nucleus. From these 4,000 damages, 3 to 40 are double-strand breaks. The cells can recover from this attack because they have remarkably efficient repair mechanisms. The mechanisms for repairing double-stranded breaks, though, are not that accurate. This is why double-strand breaks are the most critical for cell kill. But how does a cell react to radiotherapy? Which dose is required for killing a tumor cell? This question is answered by the so-called cell survival curves. As you can see here, we have the surviving fraction in a logarithmic scale and the dose in the x-axis. As dose increases, less cells survive from the radiotherapy until we reach a point where all cells die, both tumor cells as well as normal cells. But you can clearly see that the relationship between cell kill and dose is not linear. There is this shoulder that is being built in this low dose area up to 2 gray. This shoulder is very important characteristic of the cells and is being exploited in radiotherapy, as you will see in the next slide, in order to kill the tumor cells while preserving the normal cells. So let's see what happens when we irradiate a tumor which has healthy tissue around it. These are the cell survival curves for a single fraction radiotherapy for tumor cells with red and healthy tissue with green. As you can see, the tumor cells have a steeper shoulder than the healthy tissue have, which have a wider shoulder here. As dose increases with a single fraction radiotherapy, you see that the healthy tissue is more sensitive, and there is no dose point where we can completely kill the tumor cells without having killed the healthy tissue before. So how do we manage this problem? The answer is fractionation. We start by giving 2 gray, where we know that healthy tissue is less damaged than tumor cells. On the next day, we continue, and the cells do from where we have left them. And so we continue giving around 2 gray per day, ending up to a dose where all tumor cells are killed, but few of the healthy tissue are killed. And since this graph is semi-logarithmic, this constitutes to a big difference. Remember, this would happen if we have given a single fraction radiotherapy. Fractionation is one trick we use in radiotherapy in order to spare the surrounding healthy tissues. The other one is to deliver the dose precisely to the tumor. Our physicists have shown you before how radiotherapy has been developed over the years and how we can nowadays be millimeter precise. This short video summarizes what we discussed about the biological effects of radiotherapy. You see how photons interact with the DNA, causing damage, leading to tumor shrinkage. Now, having learned the basics and how radiotherapy works, let's go back to clinical oncology and to our case. You see here a patient with a tumor in the lung, representing a localized disease. And here, a patient with a metastatic disease. The red spots represent metastasis. As you can see from the bars on the top, as we move away from the local disease, the value of local therapy shrinks and systemic therapy becomes the treatment of choice. But recently, in modern oncology, a new term has been developed, the oligometastatic disease, where the metastases are limited in number and in organs. You see in this example, 3 metastases. In case of oligometastatic disease, we have evidence that local ablative therapies in all metastatic sites can lead to improvement of overall survival and progression-free survival. Similar to the oligometastatic state, there is the oligoprogressive state. Oligoprogressive disease develops on the background of a polymetastatic disease. Oligoprogressive disease occurs following an initial response to systemic therapy, where disease progression only occurs in a limited number of sites. In this example, this metastasis. Oligoprogression is felt to arise as a consequence of tumor heterogeneity and the development of an isolated resistant subclone at only one or few metastatic sites. Oligoprogressive disease is increasingly encountered in clinical practice due to the widespread use of molecular targeted treatments with the potential for the development of subclones with drug resistance. In EGFR mutated lung cancer, targeted therapy, the so-called tyrosine kinase inhibitors, compared to standard chemotherapy, is associated with improved outcomes. Unfortunately, resistance to TKIs is inevitable, and at some point, all patients on targeted therapy will progress. Identifying those patients with oligoprogressive disease who progress only in few sites may be important because there is potential to prevent the development of widespread resistant disease from the propagation of drug-resistant clones. Removing a progressive clone may slow or prevent this process, allowing prolonged therapeutic benefit from the current line of systemic therapy. So what are the treatment options for oligoprogressive disease? First, to change the systemic therapy. Second option, continue with the same therapy if progression is minimal. And third option, to use local therapy and continue with the same treatment. An increasingly common method for treating oligoprogression in non-small cell lung cancer patients with driver mutations is to continue the TKIs, that is controlling the greater proportion of the disease, while using local ablative techniques such as stereotactic radiotherapy to eradicate the resistant clones in the area or areas of progression. The evidence for this treatment strategy comes only from retrospective studies, which are inherently susceptible to selection bias, and the lack of the control arm precludes definitive conclusions about the true value of local ablative techniques in this setting. However, based on this limited data, the NCCN guidelines currently recommend this strategy. Ongoing clinical trials conducted specifically in oligoprogressive oncogen-driven non-small cell lung cancer will help to provide prospective evidence for the use of this strategy in this situation. So we have the evidence for conducting stereotactic radiotherapy in oligoprogressive disease. I just remind you what stereotactic radiotherapy is. It is a modern technique of external beam radiotherapy, which accurately delivers a high dose of radiotherapy in one or few fractions. So let's go back to our patient. We took into account up to this point all previously described aspects of modern medicine. We know from the NGS that the tumor has EGFR mutation. The patient had targeted therapy, it responded to it, but molecular imaging, PET-CT, revealed us a progressive metastasis. So in our multidisciplinary tumor board, we decided to proceed with stereotactic radiotherapy of the lesion. This here is the progressive metastasis, and here is where we have to apply stereotactic radiotherapy. To do so, we have first of all to do a CT scan, which will account for the movement of the tumor during the breathing cycle. If we want to be millimeter precise in the delivery of radiotherapy, we have to be sure that we enclose the tumor in every possible position it will reside while the patient breathes. This is the planning CT we performed in order to delineate what we want to be irradiated. You can see here in axial plane the tumor, here in coronary and in sagittal view. And you can see as a secondary volume the 4D CT, which merges scans from different breathing phases and shows us how the tumor moves during the breathing cycle. You can see it better here in the coronary view. We delineate the tumor in each phase and we create this integrated tumor volume. We then add a small margin to account for any possible small move of the patient during radiotherapy. And we finish delineation with the organs at risk. You see here the right lung, the left lung, the esophagus, the spinal cord. And actually, this is what the radiation oncologists do with the planning CT. He delineates what should be irradiated and what should be avoided, and then transfers this data set to the physicists who do the radiotherapy plan. And this here is the radiotherapy plan. This is how the patient was irradiated. You can see in red the high dose region, which takes the shape of the tumor here. And with yellow, green, and pale blue, the lower doses. The pale blue is only 30% of the prescription dose in the tumor. So you can see how precise stereotactic radiotherapy can be and how well the surrounding tissue can be spared. The patient received 8 fractions of radiotherapy. And what is the clinical result? The patient continues treatment with osimertinib after stereotactic radiotherapy as per the protocol for oligoprogressive disease. A recent CT scan shows remission of the irradiated metastasis and stable disease elsewhere. She has a normal life without treatment-related side effects. 3 years, almost 3 years after her initial diagnosis with polymetastatic non-small cell lung cancer. And this brings us to the end of our webinar. I hope that we managed to show you how we combine our diagnostic and therapeutic tools in modern oncology and how modern oncology based on computational biology evolves towards personalized cancer treatment. I leave you with the view we have from our center. Unfortunately, due to the circumstances and the restrictions we all have owing to COVID, we could not host a seminar in our premises. From us all, Alexia from NIPD Genetics, Elena, our medical oncologist colleague in Thessaloniki, Alexis from the Nuclear Medicine Department, Yanis and Paul from the Department of Medical Physics, and from myself, we would like to thank you for your attention, and we are now at your disposal for any questions you might have. Thank you very much again.
So hi again, and initially I would like to thank everyone for your time and attention, and hopefully you enjoyed our webinar. Now, please follow us, and we'll guide you through in order to get into our simple questionnaire through Mentimeter. And in order to do this, please visit the menti.com website and insert the code which is mentioned here, 7162199. Once this is done, which will take less than 10 minutes, please do the evaluation form, which again through menti.com, you will have to insert the second code, which is mentioned in this slide, 7775060. Please have in mind that you have to do it before the end of the day, as this code will expire. So now let's go through the questionnaire. I will give you 1-2 minutes in order to get into menti.com and insert the correct code. So now I guess you can see the first question, so you can answer, and then the right answer will be shown, and then I will move to the next question. So the correct answer for the first question is number 1. We move on to the next question. Correct question is number B. Correct answer, the third one. Correct answer, the second one. Again, the second answer is correct. Answer C. Answer B. Answer C. 4 more questions to finish the questionnaire. Answer D. Answer A. Answer A. And the last question. Answer A. Thank you very much for completing this questionnaire. Now let me show you just how the evaluation form will look like. And please complete it as soon as you find some time, because as I told you before, the code will not last for long. So now let's see in the chat. I see there are some questions.
Hello, I'm Konstantinos. Sorry, we have a question about PD-1 and PD-L1 levels. This is something that we try to find the percentage of the PD-L1 levels in cells, in tumor cells, in order to give patients immunotherapy, the neuro drugs. Actually, this patient had less than 1%, so it's regarded as negative. But in any case, if it were positive, we would start with TKI treatment, because it is the effect is faster, and we would start with TKIs in any case. But in patients with high PD-L1, this is a very good option as a second-line treatment. We have to wait until the patient progresses, because she will progress, unfortunately, in the future. And then we have to reconsider which treatment we'll give for second line. We could use chemotherapy or chemotherapy plus immunotherapy. We have some options, but in patients with mutations in driver mutations, it's wiser to start with the TKIs. They have a faster treatment effect. So if there are any other questions, would be happy to answer them. If not, we suppose that you understand everything, so you can start oncology with us. It was a long talk. So if we don't have any other questions.
Thank you very much for your attention, and hopefully you enjoyed it. Bye.